Just to give a context to what we're going to be doing today. In our first tutorial, we looked at the skull, which is really what encases the brain, the outside covering, the protection of the brain. At the next tutorial, we looked at the biggest part of the brain, which was the cortex, and we dealt with the cortex. At the following tutorial, we dealt with all the subcortical structures, of which there are many. Then with the last tutorial, we zoomed in and we looked at the brain at a cellular level and those very, very fine details of how the cells work, how they transmit messages, and those finer details. And now today, we're going to start looking at the neuropathology. And included with that, we're going to be dealing with imaging. Because it is through the neuroimaging that we often detect pathology. So I've linked the two. You will be dealing with more pathology later on in the tutorials, but the pathology that was of relevance today, we're going to be dealing with today. Amongst the pathologies that we're going to be looking at, we're going to be looking at traumatic brain injury, and you're probably aware that in the field of neuropsychology in South Africa at the moment, most of our work is in the field of traumatic brain injury, as people have had motor vehicle accidents and as the Road Accident Fund needs people to be assessed so that they know to what extent they've been injured in road accidents. So that has been making up the bulk of our work that we do, but that is going to be changing quite rapidly now, as the Road Accident Fund has also changed their policies. They're going to be needing certainly less attorneys, and they're going to be needing less neuropsychological assessments. So we're going to be branching out into more the other types of pathologies, like your dementias and your epilepsies and your brain tumors, etc. So that is why it's important to know all of this information. Okay, so we're going to be dealing with alcohol-related disorders, your chronic alcoholism, which has a certain effect on the brain, your alcoholic dementia, which is slightly different to your chronic alcoholism, and then Korsakoff syndrome, which you would have heard me mention before, where a person has been drinking excessively and it's paired with poor nutrition. People then sometimes get Korsakoff syndrome. So you're going to be reading about that. You're also going to be learning about the effects of street drugs on the brain, such as marijuana, cocaine, opiates, and methamphetamines, which is TIC, and polydrug use, poly being many, so the effects of many different drugs on the brain. And then your social drugs, like caffeine and nicotine. Okay, now, in addition to all of that, you're going to be reading up and learning about toxic conditions that we don't encounter all that often, such as environmental and industrial toxins, your solvents and fuels, your pesticides, your metals, and formaldehyde. And apparently the brains yesterday they weren't in formaldehyde, they were in a different substance. So I don't know if that was try and preserve the brains of the medical students as they're studying all of this. In addition, you're going to be learning about HIV and AIDS. You're really going to be covering a lot in this month coming up, but I'm sure you've gotten used to the pace of this course, and you realize that there is quite a lot to keep doing. And herpes, simplex encephalitis, Lyme disease, which is a tick-borne infection, and chronic fatigue syndrome. Of course, the brain needs oxygen. It uses up a lot of oxygen, and when a person is oxygen deprived, it is your brain that is affected the most. So you're going to be reading about anoxia, A meaning not, so not getting any oxygen in, hypoxia, which means too little oxygen, and carbon monoxide poisoning. If somebody, for example, tries to poison themselves with the fumes of their cars, it has a certain effect on the brain. Something else that you'll read up about is people who climb up very, very high mountains on a regular basis where their oxygen is very thin. They also have certain side effects from that, and you're going to be reading up about that too. You'll be reading about folic acid deficiency, the effects of vitamin D, and if a person has anorexia, of course, they're also getting nutritional deficiencies. So besides all the other effects of it, it also affects their cognitive functioning, their brain functioning. Now, to be able to understand traumatic brain injury, which I'm going to talk about in a moment, where there's loss of consciousness, one's got to ask yourself, well, what is consciousness? And there's an interesting chapter in the Cole book, the textbook that you have on consciousness. It's perhaps not what I would have defined as consciousness, but he examines what one is really looking at, what consciousness is. And he divides it into mental images and consciousness. And then, of course, if you think about consciousness, you've got to think about loss of consciousness and how conscious are people and what would cause loss of consciousness. So you're going to be learning about that this coming time too. So let us look at traumatic brain injury. I've already mentioned some of this before. Here is a picture of somebody that gets hit on the head with a ball. I don't know what type of ball that is. Is that what, a cricket ball? Basketball? Baseball. Baseball, okay. And what tends to happen is the brain, the ball hits the head, the head swings to the one side rapidly, so the brain hits that side, and then your head goes back and the brain hits the other side. Now, this wouldn't result in a very serious injury. Of course, if one has a motor vehicle accident where you're traveling at a speed and that car suddenly stops, it hits something or something happens that makes it slow down very quickly. Your head goes forward, the brain hits the front of the skull. Your head goes back, the brain hits the back of the skull. And you typically have a coup and a contra coup injury. Coup being in the front, contra coup being at the back, in the case of a motor vehicle accident. Here, your coup is on that side and contra coup is on that side. So it really depends. And of course, if a person is traveling in a car when there's an accident and they were looking towards the side at the time, the impact of that injury is much more severe because you also then have rotational forces that come into play. Now you get open head injuries, which as neuropsychologists we don't see all that much of, but our hospitals do. By open head injuries, I'm talking about stab wounds, being hit with hammers, things like that. And then you get your closed head injuries, which we see a lot more of. Your mild traumatic brain injury, and traumatic brain injury is normally indicated as TBI, and mild traumatic brain injury is MTBI. So if you see that acronym somewhere, that's what it means. I know you probably already know that, but I'm just mentioning it. Then you get your moderate traumatic brain injury and your severe traumatic brain injury. And what we use for the classification of that, as I have said once before, you look at the person's loss of consciousness, you look at their Glasgow Coma Scale, and you look at their post-traumatic amnesia. And you'll be just going over all of that again this coming month. When you do an assessment of a person who's had a post-traumatic brain injury, a traumatic brain injury, one of the things you need to look at, very important, is their age. It's very different if it's a child compared to an adult. It's also different if it's an elderly adult compared to a younger adult. And when we look at brain development later in the tutorials, you'll see why it is so important. So it depends on the stage of development that the brain is at. If it is a child who has a traumatic brain injury, that brain is still in the process of developing. So not only do you have the injury to the brain tissue at the time, but it interferes with the continued development of that child's brain, depending, of course, on the nature of the injury, where the injury is, and the severity of the injury. So when you're looking, if you're doing neuropsychological assessments on children, you need to be aware that it is much more complicated than doing assessments on adults. And if you're quite new at doing neuropsychological assessments, rather start with adults until you're used to it, and then you can do so with children. You also need to take into account if there have been any other traumatic brain injuries that this person has occurred. For example, concussions. Let's say it's a rugby player and he's had 3 or 4 concussions in his lifetime, and now he has a car accident and has a traumatic brain injury as a result. Those previous concussions are going to have an effect on the amount of damage that is done in the car accident. One needs to look at polytrauma, more than one trauma. So if a person, for example, has had their lungs collapse, well, then you know that we had a problem with oxygen, or might have had a problem with oxygen to the brain. So then you need to look at the finer details in the medical notes. What is the oxygen saturation throughout the period from the accident until they are out of hospital? And alcohol abuse, one needs to look at that because that also has an effect on the brain at a time of injury. And then in your reading material, you're also going to be covering the less common sources of traumatic brain injury, such as electrical and lightning injuries. There are people who get struck by lightning. And injuries from blasts. Now, a lot of this information you're going to be reading up in LESAC. We haven't done much in LESAC so far, but LESAC's chapters on neuropathology are very good. And this is where LESAC is going to be coming in quite extensively. So let us look at brain imaging. Our progress in neuropsychology has a lot to do with the progress in brain imaging. We have learned so much about the way the brain works from doing research as a result of imaging. Before imaging, the only way we knew how the brain works is if somebody had an injury in that area, and we could then say, okay, well, they had, for example, a pipe, going through the frontal lobes, and now we see how the person's behaviors change, so we attribute that to the frontal lobes. Or upon autopsy, we see, oh, this person had a tumor. Now we understand why I couldn't speak, because the tumor was in that area where Broca's area is, for example. But now we have imaging. So we can look at how the brain functions while the person is still alive, and so we have learned so much about it. But imaging itself has developed a lot, and it's important as neuropsychologists to understand the different types of imaging, because you're going to be reading the medical reports, and you need to know what the images can and cannot pick up on. So let us have a look at this. Okay. Now, our two main types of scans that our patients have are either CT scans or MRI scans. And I want to go through the differences with you, because there are important differences. The CT scan, you'll see, okay, that's a CT scanner machine. You will see that this section here, obviously the person lies on the bed here, they get moved in, and depending on the area that they need scanned, in our case the head, person will be moved inside. The head is inside of the circle. And you see this CT scan machine is not very wide. It's about this wide. Okay. Now, one of the advantages of a CT scan is that it's very quick. So it's very good for emergencies. Somebody has just had an accident, the ambulance brings them in, they've lost consciousness, and the doctors need to know, have they lost consciousness because there's bleeding on the brain or swelling of the brain, in which case they need to operate urgently. So a CT scan is going to tell you that, and it's very effective for emergencies. A CT scan is also less expensive than an MRI, so it makes sense financially for hospitals to do CT scans. But you get radiation exposure if you have a CT scan. It's like having a very intense X-ray. So it's not good for your body to have a CT scan. And young children, ideally, should not have a CT scan unless it's really important. So one has to weigh up, or the doctors need to weigh up the advantages and disadvantages of having a CT scan done, particularly if it's a child. Or, for example, a pregnant woman. You're not going to want to do a CT scan on a pregnant woman because of that radiation, unless it means that she might die and the baby dies with it. So they need to weigh up all these things. And an advantage is that if a person has metal implants, they can have a CT scan done, but it can't take large people. Nobody over about 204 kilograms, so that's quite large. They just don't fit in there. But another advantage is that it doesn't usually cause claustrophobia in people. The MRI scanner, that is what it looks like. Also have this bed that you lie in, it slides in there, but it's a much wider machine. And it uses a powerful magnet and pulsing radio waves. I've seen a photograph of a hospital bed that got too close to an MRI scan and got zipped up to the MRI scan and attached there. But the advantage is it has much higher definition pictures, higher details in the soft tissue differences, and I'll show you in a moment the differences between the pictures of the CT scan and the pictures of the MRI, much clearer. But it takes longer. It takes about 30 minutes. So if it's an emergency situation, you think this person's bleeding on the brain and you need to operate urgently, you're not going to want to do a 30-minute MRI scan. And it is much more expensive. But you don't have radiation exposure. So it's safer for children, safer for pregnant women, safer for people generally. But you can't... I'll get to that now. You can't scan people if they have metal implants, if they have tattoos, or if they have pacemakers. Many people have metal implants. So let's say they've been in a previous accident and they have a pin in their arm or a pin in their leg. They can't have an MRI. Or you get some people with bullets lodged in their bodies that the doctors decide just to leave the bullets there because it's actually not doing any harm and it would be too dangerous to take it out. Well, then they can't have an MRI scan. And if you have a pacemaker, you can't have an MRI scan. Teeth fillings apparently don't get pulled out. I don't know why. the fillings are okay. And then it cannot take people that are larger than 159 kilograms. So there you're quite restricted with the size of a person. And then people tend to feel claustrophobic in an MRI. I don't know if anybody's ever had, you've had an MRI scan done?
Yes, myself under self-diagnosis.
Okay.
And I had no problem with that. But my wife had one for her neck.
Yes.
She had to be injected.
People find it extremely traumatic. If a patient tells me that they need to go for an MRI, I always just warn them. It's very noisy. And as long as you just know that, the noise is normal, it is noisy, it will pass, they're better prepared for it. It's not a very pleasant experience. They have to lie dead still. They do get a little button usually that they can press if they're feeling a bit panicky. But they have to lie very still for 30 minutes with this terrible noise around them. Young children need to be sedated because it's a bit frightening for them, and some adults also need to be sedated to have an MRI scan done. That is what a CT scan looks like. That is what an MRI scan looks like. And if you look at it carefully, you can see the CT scan is very grainy, whereas the MRI is much clearer. And that is why an MRI in so many ways is a far better scan to have done with all the circumstances taken into account. Now let's look at a normal CT scan, and then we're going to look at some abnormal CT scans. Your normal CT scan, your skull is white. It's projected as white on your CT scan. And the left side of the scan is the right side of the body, and the right side of the scan is the left side of the body. And you need to imagine that you are viewing it as if you're looking up from the patient's feet. Now, I've heard that told to me several times. I always struggle to imagine looking at a person from their feet up. So I just try and remember left is right and right is left. The shapes of the ventricles are quite distinctive. Here you can see the lateral ventricles, the frontal horns of the lateral ventricles, the third ventricle, and they're quite clear. The third ventricle, that yellow one over there, if the third ventricle is either not visible or shows signs of shift away from the midline being the middle here, this suggests that there is an abnormality. The basal cisterns. You'll usually see, if you read a radiology report, they'll always mention whether the basal cisterns are patent or not. And patent means that they're open. The basal cisterns is a fluid-filled space around the back of the midbrain. Blood clots or swelling of the brain may cause this to become narrowed or not visible at all. So that is why the neurologists always look at the basal cisterns. And the frontal horns of the lateral ventricles, over there, are symmetrical, with a septum between them in the midline. Okay, so there you've got this septum between them at the midline. So that's your normal CT scan. Now let's look at a CT scan with acute subdural hematoma with a midline shift. There we go. You can see here's your midline over there, those little dots. And you can see how these ventricles have shifted over. So the true midline has been outlined by yellow dots. Frontal horns of the lateral ventricles have been pushed over to the left. Remember, this is the left side, that's the right side. The third ventricle is now not visible at all. It's difficult to make out the basal cisterns. Whoops. And you can see here is your contusion. And usually on the brain scans, it's actually very clever. They can measure the distance. So you can see here they've measured 1 centimeter distance from the midline. Subdural hematoma, you know, is bleeding under the dura. And of course, as it bleeds, it takes up, it has a mass effect, and then it pushes the brain. Diffuse axonal injury. Often if a person is in a car accident or if you bump your head very badly, you have diffuse axonal injury. It's because that damage goes throughout the brain, so the little axons get injured, get damaged. And this is now your normal CT scan. This is one with diffuse axonal injury. You get petechial hemorrhages that occur at the interface of the gray and the white matter. So I mean, this is the thing about a CT scan. You can't see the difference between the gray and the white matter all that easily, but you know it's more or less there. So here the little petechial hemorrhages have been highlighted in yellow for us. Here the lateral ventricles, third ventricle, here's your basal cistern. Your little hemorrhages can also occur in other areas of the brain substance. It is often a characteristic of diffuse axonal injury that there are numerous petechial hemorrhages, but no evidence of brain swelling or midline shift. And you need a radiologist with a very keen eye to pick up on these little hemorrhages because you don't really see anything else that's wrong. Of course, as a neuropsychologist, you pick it up much more easily because you see the effect of it on your tests. And that is why usually attorneys and so on would prefer to send the person for a neuropsychological assessment than just rely on the imaging. Difficult. Now, cerebral contusion. The contusion is kind of a bruising of the brain. Here's your normal CT scan. Here's your one with contusion. You have extensive bruising of the right side of the brain showing up as a large diffuse gray area. You can see the gray there, dark gray. Patches of white within the gray area represent bleeding. And the area of the cortical contusion is outlined in purple. So there's your contusion with it colored in, but that's the gray. You can see how well trained the radiologists really need to be able to pick up on all these little things. Now let's look at the MRI scan. We're now moving away from CT scans. Let's look at the MRI scan of a person with Alzheimer's. Here's your normal brain. Here's your Alzheimer's brain. You can immediately see, here your sulci and gyri, you can immediately see these big gaps. That brain has no atrophy. This one has severe atrophy. The hippocampus, now remember this, in this picture it's sliced this way. Okay, so you're looking at the person in front like this. The hippocampus is outlined in red. You can't see it so clearly on the screen here. There's your hippocampus, which is nice and plump in the brain with no atrophy, but it's very thin in the brain where there is Alzheimer's atrophy. And you know that the hippocampus is responsible for forming memory, storage, and organizing information. The entorhinal cortex is outlined in blue. That's it over there. It is also responsible for memory and navigation, and you can see with the Alzheimer's brain how much thinner it also is. And your perirhinal cortex is outlined in green. It's responsible for object perception, memory, and associations. And again, you look at the person with Alzheimer's and you see how very atrophied that is. One usually also looks at, besides the atrophy of the gyri and sulci on the outside, you also look at the size of the ventricles, because as the brain cells die off, it shrinks, the brain shrinks. So your ventricles get bigger because there's more space. So you see these big ventricles. The radiologists normally talk about, well, they normally look at the size of the ventricles as well. Now, multiple sclerosis, you're going to be learning about multiple sclerosis. This is what the MRI looks like for somebody with, typically, somebody with multiple sclerosis. Again, it's not all that easy to pick up, but you have these little white spots on the brain, and usually around about here you have this white blush, and that's usually a sign of multiple sclerosis. So you're going to be learning about that quite a bit this coming month. And then brain tumors, here you can see this bright white tumor that stands up. You can also see how it's pushing this part of the brain away here as this tumor grows. So the tumors on the MRIs normally look bright white, depending on what type of tumor it is. You get some tumors that are fluid-filled, that form a cyst, and then you'll have this bright rim around it and a darker inside. Yes. It varies. It varies. We have, at the radiology meetings, and I'm hoping you're going to join me at some stage, we have this very expressive and interesting neurosurgeon who quite likes to tell us what that tumor looked like when they took it out. And sometimes it's red, sometimes it's white, sometimes it's quite fatty, sometimes it's pus-filled, sometimes it's blood-filled. I don't always want to know all of these things. But so it really depends on the type of tumor. And some of the tumors are very well contained. Others tend to just spread all over into the brain. Obviously, those are a lot more difficult to remove. But he normally tells us if it just kind of slips out quite easily. We don't often encounter PET scans in our work. We normally have reports of CT and MRI scans, but you need to know what a PET scan does. Now, a PET scan is positron emission tomography. I just want to say quickly about CT scans. People often refer to them as CAT scans. You probably know that. Okay. So now you get a CAT scan and a PET scan. This is a PET scan. The PET scanning machine looks very similar to your CT scanner. And in this particular diagram, your white to red to green to blue colors indicate maximum to minimum levels of blood flow. So your PET scans, they look at blood flow in the brain. Then you get functional magnetic resonance imaging, and these are the typical pictures you get with those. The functional magnetic, it's an MRI, but while the person is in the machine, it's not a static picture. It looks at the movement of information in the brain, or as the signals change in the brain. Very useful for studying, for research and studying the brain. Then one of the newest ones is your DTI, which is diffusion tensor imaging. And if I'm not mistaken, it doesn't say anything about this in... No, I think in the latest LISAC it does mention this. In the older LISACs it doesn't. It allows a mapping of the diffuse process of molecules, mainly water, in biological tissues, in vivo and non-invasively. So it's not an invasive process. It reveals abnormalities in white matter fiber structure and provides models of brain connectivity. So you can see all these pictures, those are the white matter pathways that are beautifully highlighted like that. And its main clinical applications are for the study and treatment of neurological disorders. And it's rapidly becoming a standard for white matter disorders. So if you suspect a white matter disorder, such as multiple sclerosis, people will be doing more and more of these scans. Then you also get angiography. It's where a substance that absorbs X-rays is injected into the bloodstream. It's not toxic, obviously. And then you get these beautiful pictures of the blood vessels. You can see here, this is the heart down here, how these arteries come up here and into the head and branch off. And angiographies are used mostly if it's suspected that a person has an aneurysm, which I'll get to in a moment, or if there's been an artery that has been bleeding. Now, while we're talking about arteries and veins, I just want us to revisit the circle of Willis. This is just a diagram of the circle of Willis, which makes it a little bit easier to learn all the names of the arteries. You do need to, unfortunately, know the names of these arteries in here. And this is the circle of Willis in the context of the brain. And it's made up of the anterior cerebral artery, left and right, the anterior communicating artery, the internal carotid artery, left and right, the posterior cerebral artery, left and right, and the posterior communicating artery, left and right. And this is an angiogram of the circle of Willis. You can see how it runs there. Just more about the circle of Willis. The basilar artery and middle cerebral artery supplying the brain are not considered part of the circle. And this is an important thing about the circle of Willis. If one part of the circle becomes blocked or narrowed, or one of the arteries supplying the circle is blocked or narrowed, blood flow from the other blood vessels can often preserve the cerebral perfusion well enough to avoid the symptoms of ischemia. You know ischemia, stroke, where the blood vessel is blocked? But with the circle of Willis, because of the nature of the blood flow, if one area of the circle of Willis is blocked, you're not going to have a stroke because the blood flows around it and the rest of the brain can get blood. But that only applies to the circle of Willis. Now, you're going to be learning in more detail about the various pathologies of the arteries and veins. You're going to be learning about the cerebral ischemia, stroke, which consists of either thrombosis, which is blood clot in a vessel, like this, or an embolism, where a blood clot from a larger vessel flows down and blocks a smaller vessel, where there's reduction in blood flow through cerebral arteriosclerosis, where cholesterol packs on the inside of the arteries and the arteries become thinner, and transient ischemia, where there's a stroke for a moment. Something blocks that little pathway and then moves through. But for the moment that it's blocked, the person, for example, can't speak or can't move with one side of their face, for example. You're also going to be learning about migraine strokes, cerebral hemorrhage, bleeding, angioma, which is a congenital collection of abnormal vessels that divert normal blood flow. I mean, I'll show you pictures of the circle of Willis and so on, and it almost looks as if everybody's veins and arteries look that way, but there's actually quite a bit of variation in people, and some people are born with very strange aberrations, and one never knows it until the imaging is done for some other reason. And it doesn't necessarily cause any problems, but sometimes it does. And then aneurysms, here's a little picture of an aneurysm. It's like this little balloon that pops up with an artery. And many people have aneurysms their entire lives, and it's never a problem. But sometimes those little aneurysms burst, and that's when you have bleeding into the brain and a stroke. And then edema is the swelling of the brain. I've put this other spelling of edema in there too. In South Africa we spell it that way, but one often sees it written that way as well. More about pathology regarding the arteries and veins. We're looking at headaches. Now, pain caused by pressure displacement and inflammation causes headaches. Pain-sensitive structures are the dura mater. I'm sure many of you will remember the dura mater from yesterday. The dura mater, large arteries of the brain, branches of some of the cranial nerves. They're quite sensitive. So when there's dilation of the arteries, then you get a headache. Migraine headaches are one of those things that are just, the doctors are really struggling to try and help people who have migraine headaches. Greek, hemi means half, and cranion means skull. People with a migraine, they get an aura where they just have this sense something's not quite right with them. So they often detect that they're going to be having a migraine, and it's a constriction of one or more cerebral arteries that produces an ischemia of the occipital lobe. So normally people who feel a migraine coming on, they have visual sensations, and that's because of the constriction in the occipital lobe, where the visual areas are. So you'll see little funny lights. How many of you get migraine headaches? It's quite a common thing. Little lights, or it's looking kind of blurred, and that's because of the constriction in the occipital lobe. The actual headache begins as the vasoconstriction reverses and vasodilation takes place. So you've got those little arteries that constrict, and then as they relax, that's when you actually get the migraine. You get different types of migraine. Classic, common cluster headache. You get a hemiplegic migraine, which is loss of movement of limbs on the one side. Hemi, of course, being half. And ophthalmologic migraine, which is loss of the movement of your eyes, which I've never actually seen anybody or heard about, but you do get it. And then other headaches associated with neurological disease include muscle contraction headaches and non-migrainous vascular headaches. Now let us look at the types of brain waves. It's now a different section that we're going to be looking at. We have different types of brain waves, and I just want to take you through it because you're going to be learning about it in depth. You get your beta brain waves, your alpha, your theta. You get a high delta and a deep delta. Those are probably your most important ones. So here you have your theta, goes like that. Your alpha goes like that. Your delta goes like that. And your beta goes like that. And unfortunately, you need to know what these brain waves do to us, what sort of mode we're in, depending on the brain wave. So to try and make it a little bit easier, I've tried to find little characters to explain it. So we've got bouncy beta, okay? So bouncy beta is when you're awake and you're excited and you're functioning well and you can study and you can attend to things, your concentration's good, that's bouncy beta. Then you get affable alpha, who's very relaxed. It's when you're in your relaxed stage, maybe light meditation. That's your affable alpha. There's your little alpha wave over there, okay? Then you get daydreamy theta. I couldn't think of any better name for him. Is when you're in that mode where you're daydreaming, you're far away. You're not asleep, but you're far away. So there's your daydreamy theta. And it's when you're daydreaming or when you're in a deep meditation, and here's your your theta wave. And the last one is dozing delta. That's when you are fast asleep. Then you have that kind of brain wave. So I'm hoping these little characters will help you remember it. Now, EEG measures brain waves, okay, electrical brain activity. EEGs record electrical activity along the scalp, okay? And it measures the voltage fluctuations resulting from ionic current flows within the neurons of the brain. And records the brain's spontaneous electrical activity over a short period of time, usually 20 to 40 minutes. But you can also have a longer EEG done if you suspect that the person is having epileptic activity and the short 20 to 40 minute sessions aren't picking it up. The recordings from multiple electrodes placed on the scalp, you've probably seen people with these electrodes on their scalp or seen pictures of it or maybe even had it done yourself. And the main uses for EEG is as a diagnosis of epilepsy, coma. If a person's in a coma, they want to know, are they still awake while they're in the coma, or are they brain dead? Now, these are little pictures of little electrodes that are placed on their head, and there are very specific areas that they're placed, and they're numbered in a certain way. Each site on the scalp has a letter to identify the lobe. So T would be temporal lobe. Okay, you can see the person's nose in the front here. F would be frontal, O would be occipital, and P is your parietal over there. So each site on the scalp has a letter to identify the lobe and a number or another letter to identify the hemisphere of the location. The electrodes positioned over the frontal lobe would be an F, over temporal T, over parietal P, and occipital O. And then odd numbers with the letters 1, 3, 5, and 7 refer to the left hemisphere. So T3 would be on the left side, whereas your even numbers 2, 4, 6, and 8 are the numbers that refer to the right hemispheres. So if you have a T4 or let's say an F8, you know it's in the frontal lobe on the right-hand side. Okay, so odd numbers on the left, even numbers on the right. And Z, you'll see these are Zs, refer to an electrode placed on the midline. Now you get an EEG printout that looks more or less like that, and as neuropsychologists we don't need to be able to read an EEG. The only reason I'm showing it to you is because we often see it, and I just want you to understand what you're looking at. And we need to understand obviously the EEG report. You'll see over here you'll get like your little F3s, and over here it tells you which area of the brain the electrode was at, and then the little line, or the electrical monitoring of that line. And on this head you have 4 electrodes placed there, and you can see the closer the electrode is to electrical activity, the larger the wave. So for this little electrode here, which is close to activity, it has this high frequency wave. When it's far away, it has a low frequency wave. Okay. Now epilepsy, you know that one gets a partial seizure, and here you can see this person's EEG printout. In the right hemisphere you've got electrical activity, and here you see the electrical activity, whereas the other side you don't. A generalized seizure, you have this electrical activity all over the brain, and that's your normal EEG. You're going to be learning about, I'm sure you know a lot about epilepsy already, but I'm just going over it. Focal seizures, generalized seizures, akinetic seizures, you cannot move. Myoclonic seizures, where people, they call it jumps, they become quite jumpy. And I'm sure you've noticed some people, as they're falling asleep, maybe you as well, you tend to jerk sometimes, and it's because of electrical activity in your brain. Now, an EEG for an absence seizure looks like this. It's normal, and then you have these little waves. You can see this person's having an absence seizure. Here you have a normal little EEG, and then here you have the onset of grand mal seizure. This is a petit mal wave. It has this sort of wave and spike effect, and the grand mal during the jerky phase, you have this sort of very jerky effect, really. Now, while you sleep, while you're awake, you have an EEG that looks more or less like that. This would indicate light sleep. This is REM sleep, very active. This is a deep sleep, and this is cerebral death, flatline. And you know that we all have sleep cycles. We start off where we're awake, and we go through the different stages of sleep. We get to the bottom here where the brain waves are very slow, and then start waking up. Then we have REM, and we go deeper, 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 start waking up, REM. And so we go through various phases until we eventually wake up. And that you will obviously be able to detect on an EEG scan. Now, something important about when you're sleeping is during REM sleep, the muscles become paralyzed and dreams occur. From the neck down, you're paralyzed while you have REM sleep, because otherwise you'll be thrashing about, getting out of bed, walking around as your mind is very active during the dream stage. And this is very important when it comes to narcolepsy, and I'll tell you why in a moment. Let's look at sleep disorders. Insomnia, we know about insomnia. This poor little guy just can't sleep. I'm sure many of you have either heard about or experienced restless leg syndrome, very unpleasant, where you feel you've got to constantly move your legs. Okay. Sleep apnea is when people stop breathing while they're sleeping, and if it's left untreated and if it goes on for too long, one eventually picks up a bit of brain damage because there isn't enough oxygen coming through to the brain. And then narcolepsy. With narcolepsy, there are different aspects and forms of narcolepsy. The one is what they call a sleep attack, where the person will be sitting here, and assuming the presenter is fairly interesting, and they'll just fall asleep. Or they'll be walking down a passage, and they'll just fall asleep. Or they'll be driving, and they just fall asleep. So of course, people with narcolepsy may not drive, and it can be very dangerous. Like this. Then you get what you call cataplexy, where, remember I said that when you are in REM sleep, you become paralyzed. Now sometimes the system goes awry, and the person can be walking, and suddenly they just become paralyzed and they'll just fall down. And it's called cataplexy. Also, where the system goes wrong is that, while you're dreaming, you have all these images. But what sometimes happens is when you're awake, you suddenly have these images. and they're hallucinations. They're called hypnagogic hallucinations. So your dream is really happening to you while you're fully awake. Some people struggle to tell the difference between the hallucination and reality. And then you go to what I find extremely interesting is sleep paralysis. And that is where you have been sleeping and you wake up, but your body is still paralyzed. And for a moment, or a minute, or maybe even two, you are awake, but you can't move. And there's been some very interesting research done into this by some Egyptian men that I met at a conference once, saying that there's a certain cultural phenomenon to do with sleep paralysis. Firstly, when people are paralyzed, but they have this sense of fear, of there's something ominous about it, a sense of foreboding. So they feel very frightened, and then they feel a pressure on their chest, and it's apparently very common. And in addition to that, they have this idea that there is somebody coming to get them. And it is very culturally specific. And these particular men have done research all over the world and found that, for example, I think it's in England or in Ireland or Scotland, there's the old hag or something like that. People are terribly afraid of the old hag. In America, it's UFO abductions. People see aliens and are quite certain they've had abductions. And I realize it's quite a controversial topic because the people are very, very convinced that this has happened. And I think in South Africa we have the Tokolosh. And I actually spoke to, one time I gave a presentation on this to some colleagues, and my one colleague said, but, and she's not from a sort of Xhosa Zulu background, but she has experienced a sleep paralysis, and to her, there's a little man coming down the passage for her. And of course, people are terribly frightened. But it passes, and they wake up, but they still remember this sense of fear that they had, and people can be quite traumatized by it. If they realize, of course, that it's just a sleep paralysis, and you can make yourself wake up from it quicker by blinking quite quickly and moving the part of the body that you can, and you wake up out of it quite much more quickly. And that is the end of my presentation. I just want to go to the list of reading. Here's a required reading.
There's only one page.
It is a lot. I wish I could tell you that you're going to be learning less and less, it's going to slow down as you go along, but believe me, it's a lot of work to cover, but it is very interesting, and maybe it looks a bit more than it is. A lot of it is repetition. So for example, some of the pathologies to do with blood supply and so on, you'll be covering in Kolb as well as in Lezak, and it's a bit of repetition. But do go through both books, go through all of these references, because the one book might mention something that the other book doesn't. Lezak, as I said here, comes into it quite a bit because she really has written quite a lot on neuropathology, which is very important. And it does, the references do jump around a little bit, but it's just, and some of the things in here you'll see you've already gone through. It's been on a previous reading list. The reason I want you to repeat it, just look at it. If you've already studied it, you know it, just be aware of it. The reason I'm repeating it here is just so that you can see it in the context of the new information that you've got. And it's just to try and help you bring all that information together. In the next tutorial, we're going to start looking at systems. Auditory system, visual system, attention system. So try and get all of the pathologies and the anatomies and things out of your way so that next year we can start fresh with all the systems. Okay. Thank you very much.